one's going through, they need protection from you. No judgment from you. You don't know what someone's going through. They need support from you, encouragement from you.
Pressure mountain, financial burden high and counting. Got your life doubting, voices in my head shouting. Keep a smile on your face, gun on your waist. Take your own life, peace of mind, contemplate. Family no idea, you see crystal clear. You not being here, your biggest fear. Being able to provide for the long haul. Rob Peter to pay Paul. Write letters, make phone calls. Affairs in order, last look at your daughter. Bow! Aftermath, bloodbath. News gonna cover that. He seems so happy, a good daddy. No signs of depression, no prior charges or weapons. Saw him take out the trash last night, not a worry in sight. Who knew it could be his last night?
You don't know what someone's going through. They need protection from you, no judgment from you. You don't know what someone's going through. They need support from you, encouragement from.
And now, how long have you been practicing?
Well, if you count my residency and the time before, I think it's about 8 years now.
8 years.
Yeah.
Okay. And right off the bat, if you could have dinner with any 3 people dead or alive, who would it be and why?
I gotta think about this one more time. Definitely Donald Trump. Why? I don't really know if I have to elaborate on that one. I'm a psychiatrist, and I just would like to pick his brain and just be like, why? Like, why? Why is this happening? Why is this happening here? So, one is Donald Trump. The other one would be probably somebody like Lady Gaga or Adele. I feel like there's like a history of trauma in the back, and I'm a very people-driven human being. I just like to know about people, like to know about what they've been through, what makes them them, and so for that reason, maybe somebody like that. And the all great Oprah, please, just like a night with Oprah is gonna be wonderful. So yeah, those 3.
Okay, that's interesting. That's very cool. What is the best or worst purchases you ever made?
Okay. The best purchase is my car that I bought for myself after residency. It was a present to myself as a, you did great, you're wonderful, here, this is a present to you. It's probably also the worst purchase because I think it was a total splurge, so I think it goes hand in hand, but I love it. I love it for myself, and it's wonderful. Yeah.
And what kind of car is it? What model is it?
It's a BMW X3.
Okay,
yeah.
All right, that's excellent. That's excellent.
So it's great because I wanted it and I bought it for myself, and it's the worst purchase because I paid it in full. So I think it kind of goes hand in hand. It was fine.
Right, definitely. Now, I have an interesting question for you.
Sure.
Would you rather lose the ability to read or lose the ability to speak?
I think I would take read at this point because I'm a psychiatrist. How can I talk all day? I can't imagine not being able to talk. And I think in this day and age with Audible and everything being things that you can hear, I think that the ability to read would be more tolerable than losing the ability to talk.
Okay. Now, I wanted to get into your work, and I wanted to ask you some questions. And obviously, you interview patients. What would you say is your interview style? How do you assess patients in the interview for suicide risk?
So, for me, every patient is different, right? You have to be what the patient needs you to be at that moment. Your own personality kind of takes a back seat when you're with the patient. You have to be what the patient needs you to be. So my interview style with the patient is exactly what the patient needs at that moment. If a patient is riled up, angry, which you're totally allowed to be, you're in a psychiatric interview, I will try to, be the opposite, temper the patient down, kind of be more of a soothing voice. And it'll be like that. If I have a younger population with me and they're more cursing, and I'll try to use their lingo. So I'm going to be what the patient needs me to be. Assessing suicidality is the exact same way. I'm gonna point blank ask them, have you tried to kill yourself in the past? If you have, how did you do it? If patients are suicidal, they will tell you. Actually being like, so have you ever tried to hang yourself? Have you tried to run in front of traffic? Doesn't mean that you're putting words in their mouth. If they have a thought, they're gonna do it anyway. So you might as well just say it. You might as well put it out there. You might as well just say it. So I actually ask them. I don't think there is any harm in actually asking them. I ask for suicidality upfront. And if you formed a good rapport with them before, they will tell you. They will. And I tell them this. You're here to get better. I'm not here to punish you. So it would be in your best interest and my best interest for you to just tell me how you're feeling. I just want to help you. So usually most of the time they're pretty upfront and forthcoming.
With suicide as we currently know it, I think that when in the past the data showed that there was no real solution for suicide or cure, or how do you feel suicide prevention is working in its current times?
So, suicide is also a very tricky subject because people think of suicide differently. Like different patients think of suicide differently. Some think of it as, when they attempt suicide, do it as an attention-seeking tactic. Some do it because they really want to die. Some do it for a totally different purpose, for their family to look at them some more. Like the reasoning for doing suicide is completely different. So, we try to do the best we can to mitigate whatever we can at that moment. What they do on the outside, I have no control over. Like I tell my patients, I'm your psychiatrist, I'm not psychic. I can't tell you what is going to happen in the future. I don't know. The meds that I'm giving you or trying to help you is just so that you can tolerate your situation a little bit better, so that you can handle your situation a little bit better and not become suicidal. Better coping skills. Does it take away the suicidality? Probably not. It just makes you feel better.
Now, our last question about suicide. Do you feel that people can recover from suicide and lead a healthier life?
Absolutely. I actually know very, very much people who've recovered from suicide and done great things with their lives. I've been fitness instructors, motivational speakers who've done great things with their lives. Yes, absolutely. Okay. Suicide is one moment in your life. It's a moment in time. It doesn't define your whole life. It's a moment in time. It's something that happened to you at that moment. It doesn't have to define your whole life.
That's a great point. Now, I wanted to segue into depression. How do you diagnose depression?
So for me, depression is not just a cluster of symptoms where the patient is going to tell you, I feel a certain way. I feel sadness. No patient is going to come with a set box of symptoms being like, I feel sad, I'm tearful. Most of the time you can actually see it. Patient will be very disheveled, kind of not showering, not taking care of themselves, lost weight, not making eye contact, not sleeping, not eating. You'll see it. It's so blatantly obvious. No interest in anything. Just a complete lack of desire to do anything. And for us, a lack of desire to do anything at all is one of the major things in depression. You could also be completely functional and look totally okay, very well put together, going to work, but have a complete lack of desire to do anything at all. To me, that's mild depression. You are functioning, but you're just living your life. You're just trudging along. This is just, what kind of life is that? To me, that's mild depression. So depression also has varying severities. Like I just spoke about like the far end of it and then the mild aspect of it. So, but Having anhedonia, which is lack of desire to do anything, is one of the classical symptoms that, at least for me, if it's there, to me that classifies as depression.
Okay. And within the depressed, let's say people who suffer from depression, what do you use to treat it?
So usually the standard is antidepressants. That's usually the standard. There have been studies to show that antidepressants are as efficacious as therapy. There are studies to show that the two of them work the best. Like the use of antidepressants and therapy together is the most efficacious, is the best in the business. Like you do therapy, you use antidepressants together, boom, you've hit jackpot. One or the other is not better than the other, like antidepressants versus therapy. Some people start with therapy, don't do well on it, and then switch over to antidepressants. But the reality is that the combination of the two is always the best. So our mainstay is antidepressants. If it's depression with psychotic features, we do tack on something, because the psychosis is not going to lift unless it's actually treated. So it doesn't have to be forever, it just has to be for that moment till the psychotic features go away.
Okay. Now I hear that a lot of patients, they don't really, well, many patients complain about the medication. They say that it makes them feel unlike themselves, they don't trust it. What do you say to people who are on the fence consistently about taking their meds?
So I do listen to them. I do, because there's a truth to what they're saying. It is true. Some medications do make you feel numb. That's their job, unfortunately. So I change it. And the patient tells me that. I do warn them. I tell them, listen, this is what's going to happen. You're probably not going to like it. Give it a day or so. If it still continues to bother you, I'll take it away. We'll try something else. Not every medication has the same exact side effect. It's like choosing pick your poison, basically. So every single medication works differently. If one doesn't work for you, doesn't mean that the other one is not going to. So I always listen to what the patient is telling me. If they're telling me they're feeling numb, if you don't like it here, you're not going to use it on the outside. So I'd rather you not like it here and tell me, I'll change it so you can be better, and then continue it on the outside. So I always listen to what they're telling me. I will change it, and we'll go with that and see how they do.
If a patient begins to take medication and they stop abruptly, will the medication have an adverse effect on them health-wise?
Certain medications have a withdrawal, certain don't. Depends on the half-life of the medication. When I say half-life, I mean once the medication has been taken for a certain period of time, it reaches steady state in your bloodstream. Like it reaches a particular concentration, and then it stays that way for some time. So if you stop the medications abruptly, some medications have a very short half-life, meaning it leaves your system very quickly. One of the ones, I can even say it, one of the ones that behave like this is venlafaxine. It's tolerated, people love it because you feel so much better on it. It makes you feel up and wonderful. If you don't take it for more than 48 hours, your body is going to tell you. You'll start feeling fluey and a little kind of muscle achy and just not the best. Prozac, on the other hand, has a very long half-life, and if you don't take it for a day or so, you're still completely okay. So it just depends on the medication.
Now, I'm aware, as I'm sure you are, that many of our patients who suffer from mental health issues, sometimes are treated unfairly, and sometimes labels are placed on them by the outside community, police. How do you feel about the fact that mental health patients have to deal with mental health labeling?
It's unfair because there is not, even though we live like in a developed country and there is so much awareness about mental health and people talk about mental health, the actual opening of the mind and like being able to understand that people's perceptions of reality sometimes can be different when they're not feeling well is just not there. It's just not there. People just don't get it. People are still looked at oddly. They're still judged. My patients tell me that there is a question that says, do you have a mental illness, in every single job application form that they fill. And to be entirely honest, it's nobody's business. Do you ask people, do you have diabetes or hypertension? So then why are you asking them if they have a mental illness? As long as it's not interfering with their ability to function and you're able to speak with them, who cares whether they have a mental illness or not? So to me, I find it to be not okay. It's not okay. because doesn't depression also come in mental illness? Then would you do that to a person who's depressed or only schizophrenic? Or are you differentiating this at all? You know, so
Yeah.
it's just, I don't think it's okay.
Right. Now, we've been in a pandemic for over a year now. I'm sure there has been some effect. We're seeing an uptick in patients coming in for a variety of mental health issues. Do you feel like the current state of the world today contributes to mental health patients suffering more, like from depression or even contemplating suicide?
So this situation that's going on currently is not even normal for normal people. Let me just put it that way. So for mental health patients, this is completely absurd. They have been sicker coming into the ER. They're falling off their meds. They have no desire to be on their meds. They are so sick, so sick. And stabilizing them has just taken much longer than we anticipate. The outpatient care also is limited because everybody's on Zoom and everything is online, and patients don't like that. Psychiatric patients need the actual human interaction, the touch aspect of it, the actual humanity aspect of it, because if you're talking to a person through Zoom and you will have a mask on and goggles on, are you really looking at a person or you're just looking at a robot? And what are your emotions that you're really emoting?
Right.
Nothing. So to psychiatric patients, that's really, really difficult. So, it's almost easier to come inpatient and just see a human being and be around people than to take your meds and be outside.
And what would you recommend people to do if they feel they are experiencing signs of depression or even contemplating suicide, based on the current,
Come to the ER. Come to the ER. We're here. Come to the ER.
Okay.
I mean, there should also, obviously, I always recommend people having their own coping mechanisms. Going to the ER is one aspect when it's intolerable, but I feel like everybody should have their own coping mechanisms. As doctors, we do things for ourselves as well, but I feel everybody should be able to do something for themselves to make themselves feel better. If nothing works, absolutely bring yourself to the ER. Come talk to one of us.
As a physician, are you limited in the range of what options you can offer as far as medication wise? Like, are you able to offer, let's say, naturopathic methods or alternative methods of treatment?
Sure. I don't see why not. I'm multiracial, so I do believe, even from my background, that we do believe in natural medication. So I'm all for it. However, certain medications do interact with allopathic medication. So we are very careful when we do these kind of things, especially ginkgo is like everybody's favorite. I have no idea why. I don't even know what ginkgo actually does. If somebody explains it to me, I might try it on my own. I have no idea what this medication ginkgo actually does, but everybody wanted to take ginkgo at some point in time. Ginkgo actually thins out your blood. And if you take it with like warfarin, or if you take it with heparin, or even more for blood thinner, you really, it's very dangerous. So you have to just be careful when you're taking natural medication because they do things. It's not as benign as people are thinking.
Okay.
So, yeah.
Now, how would you approach the care of patients who have multiple mental health issues?
The same way that I do it with everybody else. They're just harder to, they have a different way of conversing with you because sometimes they're institutionalized for so long that they don't know how to function outside. So they have a different way of conversing with you. It's sometimes very childlike and it's a very institutionalized sort of conversation that they have with you. They know about groups, they know everything that's going on in the hospital, but if you talk to them about the outside world and going to a bank and opening a bank account, they can't have that conversation with you. So it's a very different sort of conversation, but the treatment is more or less the same.
Okay. And how do you track the progress of your patients with mental health diagnosis?
So usually patients who are that sick and who come back to us over and over again, we have either ACT AOT, who keeps us in the loop about what is going on. ACT-AOT is, assisted outpatient treatment, which is basically court-ordered. So we are in the loop with them. We know what's going on with our patients in the community. Are they taking meds? Are they going to come back? Do you think that this is working for them? So that's one way of doing it. Pretty intrusive. I have to go to court for it. If the patient only comes back repeatedly, that's one way. The other thing is when we refer them to outpatient. At their first appointment, they let us know. They let my team know. They let my social worker know. Did the patient show, not show? What's going on with the patient? Were they okay? Was it a proper referral? So there is some communication that goes on, but usually when they leave us from inpatient, I like them to be more connected with the outpatient because they form a bond with the inpatient team, and I want that bond to not be as tight when they leave us, if that makes any sense.
Right.
I don't want them to go outside and be like, no, you're not my doctor. My doctor is back in the hospital. And that sometimes does happen. So I'm trying to kind of be like, no, you're going to go out there and you're going to have a new team and it's going to be a new therapist and it's going to be a new psychiatrist. It's going to be okay. So I try to limit that also. It's hard. It's hard for the patient.
Right. Thank you for sharing, your experiences.
Of course.
What advice would you give someone wanting to pursue a career similar to yours?
Do it. They should do it. But just make sure your reasons for what you're doing are correct. For psychiatry, you're either all in or all out. There is no in between. Patients can be very demanding. They can be violent. The job sometimes takes a lot out of you. You should know when to take a break. And it can be very rewarding because people don't realize that mental illness actually can be almost as bad as having cancer. Because when you tell a parent of somebody who's 18 years old that they have schizophrenia, their mind immediately goes into hyperdrive and they feel like, oh my god, this is the end of the world. And it possibly could be. I don't really know what the course is going to hold, but it's a horrible diagnosis to have. I'm sorry, your son has schizophrenia. And you're pretty on the money when you say something like that. So it's a horrible diagnosis to give someone. So you should have the heart to do what you're doing. Psychiatry is not an easy field, never. But if you're in it, you should be in it 100%. So you're either in or you're out.
In or out, that's right. And how do you unwind? What do you do? What is a hobby of yours that people would be surprised to know that a doctor may do? I don't know.
So I'm an exercise junkie. Endorphins and all that good stuff. I lost a lot of weight with while I was here. Actually, it was my second home. So while I was here, I lost a lot of weight. I lost about 65 pounds. And I kept it, that's how I keep my mental sanity, I guess. I spin a lot, I just started Pilates, I kept myself healthy, and I feel like that's what's kept me going.
So do you think that would you recommend exercise for people with mental health disorders?
So I recommend exercise to everybody, and not just people who have mental health issues. I recommend exercise to everybody, I think. And it doesn't have to be some intense, oh my god, let's just go spinning and all this nonsense. It just put on your shoes, go outside for a walk. Even that helps.
Right.
I mean, now the weather sucks, but as the weather gets better, you can just put on your shoes and go outside for a walk. And even that makes a world of a difference. Some fresh air, it makes a world of a difference. And that's how I started, just walking.
Well, so I just want to thank you, Dr. Bijlani, for sharing, because, as we spoke before, people have questions about the field of psychiatry and whether they want to enter it or not, and how would they view themselves doing the position. And I think that insights like yours are very helpful for people who are interested in or are strongly interested in the field. I think that to highlight healthcare professionals who are doing such a great work is a good thing. So I want to give you your flowers.
Thank you.
While you're beginning your career, so to speak, and because I know for a fact you do great work.
Thank you, I appreciate it.
And making a difference for people who a lot of times are treated as abnormal or not or lesser than in our community. You give people hope. So I just want to thank you for sharing and for caring and putting your best efforts into actually helping.
Thank you. I appreciate that.
Definitely. So thank you again for joining the podcast, and maybe we'll have you on again in the future.
Thank you so much. I appreciate it.
All right. Thank you very much.
Thank you.